Hi and welcome again. So we did cover together the arteries. We understood the compliance of the arteries and the fact that they have the elastic recoil, which indeed contributes to the fact that you maintain the blood flow in your vasculature even during the relaxation of your ventricles, or what we call the ventricular diastole. We went from that into the arterioles, and one major thing we need to understand about the arterioles is the fact that it is the main resistance place all over your vasculature, so vascular system. Now, it is also the place where you can modify the diameter of these vessels in order for you to manipulate your blood pressure up and down, and therefore you can manipulate the flow towards a certain area and block the flow from other areas. And we will see how that is controlled by both intrinsic, so it means within the tissue, intrinsic regulation, and also extrinsic regulation coming from elsewhere, such as hormones, adrenaline, noradrenaline, and we will also see that vasopressin and which is another word for antidiuretic hormone, is in fact regulating that the blood pressure, and angiotensin, of course. So anyhow, let's talk about the arterioles a little bit. If we remember, they don't have the elastic layer, elastic connective tissue, and they have much less of the dense irregular connective tissue. They're collagen fibers that are surrounding the big arteries, so they are capable of changing shape. They can dilate if the blood vessels choose to do so, if the smooth muscle fibers surrounding the blood vessels choose to do so, or they can constrict, and therefore they offer more resistance to the blood flow, and therefore of course the blood pressure is increasing if it's a generalized event. If it's a localized event in a tissue, then they can control the flow to that tissue without really changing the overall blood pressure, because it's only that particular muscle. They are offering vasodilation, so the blood is flowing better there, whereas other tissues, such as the skin, if you don't need it during sympathetic innervation, for example, then you can cut off the blood considerably, not completely, but considerably from there, by inducing vasoconstriction to the arterioles in the skin, and therefore you shunt the blood towards somewhere else where it's more important. So let's see how that takes place. So the mechanisms that are involved in adjusting the arteriolar resistance are either vasoconstriction, vasodilation. Now, the vasoconstriction is the narrowing of the blood vessel. The vasodilation is the enlargement in the circumference and the radius of that blood vessel. Vasoconstriction will be the contraction of the smooth muscle fibers causing it. Vasodilation, the opposite, the relaxation of this smooth muscle fibers. We need to understand what are the factors that contribute to both vasoconstriction and vasodilation, but before we get into that, let's look a little bit about the structure of these. So here is an arteriole under scanning electron microscopy, and you will see here how the smooth muscles are sort of spiraling around the arteriole in a way that when they constrict, then they will limit indeed the diameter of your arteriole, and therefore offering more resistance. Now, with more resistance, you will have retrograde pressure, because you're not allowing the blood to move in smoothly, and therefore the blood pressure is going to be elevated. And at the same time, you are also, if it's generalized, keep in mind, if it's a generalized phenomenon, it means it happens everywhere in the body, or at least where it counts. Now, the opposite is true. When you relax those smooth muscle fibers, then you will have a widening of the diameter of the arteriole, and therefore the flow will improve. If it's a generalized event, then indeed you are reducing the blood pressure, right? But if it's a localized event, then you are increasing the nutrition and the perfusion, we call it, of the tissue. So that's an important thing to keep in mind. So if you think of it this way, and we have the blood flow, and that is the artery, right? And it's going this way. And these will be your arterioles. And it depends. Do you need the blood going into that tissue? Not at all. Then you shut down the blood. It shouldn't go there. Or you need a little bit, or you are running and the muscles are really in high demand, then you open the arterioles. So the arterioles can play this role in regulating what needs more blood and what doesn't. And you will see how this is regulated by both intrinsic mechanisms, things that are secreted and generated within the tissue in order to increase or decrease the blood flow, or something that's generalized, a hormone or something that binds or a transmitter, but once it's in the blood, then we will call it a hormone, or a sympathetic innervation, a direct sympathetic innervation to the arterioles. And keep in mind, by the way, that the arterioles do not, put two lines on this, do not receive parasympathetic innervation, except in the penis and the clitoris. That's the only place where there are parasympathetic innervation to the blood vessels, and when we get to the reproductive physiology, we're going to be talking about that. Okay, so once again here, the slide you're looking at is showing you the ability of the arterioles to shunt the blood between different organs based on the need of that organ, and we will see how that happens in a short bit. Okay, now you need to understand that the brain, as we said earlier, it doesn't share its blood. So you can't shunt the blood back and forth. The brain has it to get its share. Even in the worst situation, the brain is always the one who is spared from this shunting mechanism. You cannot, just because you're running, you can't shunt the blood away from the brain. That has to be maintained because you still need the function of the brain to continue. And the brain is not going to last without oxygen. It's not going to last without glucose for too long either. So we will realize in a short bit here that we have local chemical influences that can adjust the arteriolar radius, and those are local metabolic changes, and we will talk about that in more details in the next slide. And in some cases, in pathological cases, if you have infection, inflammation, you will start to release from the mast cells something we call histamine, and we're going to talk about that later when we get to the blood system. And histamine is a very powerful vasodilator, so it can dilate the arterioles, and therefore you will increase the blood flow to that region. And all of us have noticed when we get hit, or when we are burned, or when you have a pimple that's not yet a pimple, that is usually red, and that means hyperemia. And that is one of the reasons for that is that we have histamine release, also prostaglandin release, and other stuff. But all of that will contribute to the fact that you have more blood supply to that region. We're not going to spend too much time today on the pathological cases because that belongs to the immunology, and we will cover that later on in the immune system when we get into the innate defense mechanism. But let's talk a little bit about the local metabolic changes. And if you think of it, you're running and now your muscle is demanding more oxygen. You're not going to wait for your brain to tell you that you need to, or the hypothalamus or whatever center, you're not going to wait for that to tell you that this particular muscle needs more blood supply. We have to plant a local mechanism through which you can increase the blood supply that's going to that particular tissue based on its metabolic consumption. So we will see in the next slide how that happens. Other things that are local physical influences, if you apply heat, and we all know that in the cold weather, then your skin is cold. And if you would take a warm thing and put it on your, even if you're under a blanket or something, a warm blanket, then you will see that your tissues are much warmer. So when you apply heat or cold, that can influence also the blood flow to that particular region. There is something called chemical response to shear stress, and let's pause a little bit and think of this. Chemical response to shear stress, it means when the blood is flowing through a vessel, it sort of erodes that vessel. If you think, as we said in the lecture, if you think of a river and there is a very high flow inside the river, and it will erode the banks of the river. So there is a shearing mechanism, there is a shearing effect that happens on the wall of the blood vessels if you are to increase the flow considerably too much. And the endothelial cells are capable of communicating, and they will feel that shearing effect because you are scratching against them, the endothelial cells. And the endothelial cells are going to send some messengers to reduce that shearing effect by causing vasodilation. Vasodilation meaning that they're inhibiting the blood vessels, smooth muscle fibers, and therefore you have vasodilation. Why do we have vasodilation? Because the larger the diameter of the arteriole it is, the less of the shear stress there will be inside. You understand that? So the last thing is similar to what we learned in the heart, or we learned in the smooth muscle fibers as well, in the chapter of the smooth muscle fiber physiology. The stronger the stretch, the more stretching you apply to the smooth muscle fibers, the more they will fight back. So if you have high pressure applied to an arteriole and that causes stretching of the arteriole has the capacity to fight back and contract again. So these are physical influences. Let's recap them again. Local application of temperature and chemical response to shear stress. Where are the chemicals coming from? From the endothelium, and it's sending messages, thrombospondin, and it's sending also nitric oxide, which is a very, very important message to the smooth muscle fibers. And the myogenic response, therefore we have more calcium, and when you have more calcium you have better contraction, and therefore you have better response. So when you're stretching a smooth muscle fiber, we learned before, then you will have more contraction. Let's get back to this point, which we did not elaborate much on, which is the local metabolic changes. So what happens when you increase the metabolic demand of a tissue? What happens? You are decreasing the oxygen, right, in that region, in the capillaries or in the arterioles. You are increasing the carbon dioxide, because that is the result that's coming back. You are increasing the potassium, because some of the potassium will leak. It's supposed to be inside the cell, but then with every single action potential, you're leaking the potassium out. Some of it will be drained by your circulation, and therefore you have higher potassium. Reduced pH. If you have an active contraction or active tissue, it will start burning more sugar. When you're burning more sugar, if you remember, you're releasing a lot of the hydrogen ions, and that will contribute to the reduced pH. It means the acidity, increased acidity, and as well as increased osmolarity. The osmotic pressure of a tissue will be higher, because that is always attributed to increased activity. And the adenosine release, when you're breaking ATP, you will release the free adenosine, right, or the adenosine monophosphate. And all of these factors together, right, they will contribute to vasodilation. All of them are happening because of the increased metabolic demand. Yet all of them are coming from the tissue. So we call them intrinsic factors, and they are related to the increased metabolic activity of your tissue, and that will indeed result in the increase of the perfusion of that particular region you have. Okay, so the arterioles, inside the arterioles, we would think in the past, we used to think that endothelial cells were just a barrier, just not to allow the blood from going in and out, but it's more than that. It's responding to shear effect, as you saw earlier. It's responding to all these chemicals, all these changing in the environment, whether it's metabolic changes, chemical changes, all of these changes in the environment, and they will send one of the most studied local factor that's secreted by your endothelial cells, nitric oxide and will cause vasodilation because it will act through cyclic GMP, and cyclic GMP will cause vasodilation by inhibiting the vascular tone of your blood vessels. Okay, so there's a lot of other functions for the nitric oxide, and we don't have to worry about all these functions yet, because as we progress in our learning, you will understand now that the nitric oxide has so many functions. And so for now, we're just gonna pass through this slide. What's really important here is just this last one, is that the fact that nitric oxide directs the flow to oxygen-starved tissues, right? All of the past things we learned about, it's called active hyperemia, which means that you have the tissue being active and therefore more blood supply. That's why we called it active hyperemia. You can have inactive hyperemia or reactive hyperemia if you starve the tissue from blood and then release the tourniquet or whatever you add. And we all saw that when we were playing with the sphygmomanometer. The minute you release the your sphygmomanometer off your arm, then the forearm is really red, but that's because of what we call reactive hyperemia, because you cut the oxygen supply for a while, for a few seconds or so, to your arm, and the minute you release that, then all the blood vessels are open, and that's why we call it reactive hyperemia. It's not the active hyperemia. Okay, so that was the intrinsic control. So let's talk a little bit about the extrinsic control. Now, primarily, it's the sympathetic nerve influence. We have alpha receptors in the skin and the gastrointestinal tract, and the beta-2 receptors that are in the heart, and they're predominant in the muscles. And in the muscles, they will have also the alpha, but they have mainly the beta-2. And we will learn more about these receptors when we get into the autonomic nervous system. But for now, there is a nice table in your book which compares the alpha-1 and the beta-2 receptors. And you will understand the alpha-1, the stimulation of the alpha-1 receptors will result in activation. So they will result in stimulation of the vascular tone. That means there will be constriction. So it will make sense that when you activate the sympathetic nervous system, you will have vasoconstriction of your blood vessels that are going to the gastrointestinal tract, because you don't need that now. You are not in a situation where you want to digest that food. You are in a situation where you want to use the nutrition for your muscles, for your brain, for areas that count, but not necessarily the intestine. So you shunt the blood away from the intestine, also the skin. That's why when we are afraid, our skin gets cold, because of shunting the blood away by closing the arterioles through the stimulation of the alpha-1 receptors. Now let's look at the beta-2 receptors. Beta-2 you will see in the areas that really count during exercise or activity: the heart, the muscles. And so when you activate those, although it still is a sympathetic innervation, but it will result, because it's a different receptor, it will result in vasodilation instead. So we have alpha-1 causing vasoconstriction, beta-2 will cause vasodilation. Okay? Now, we will learn, we don't have to worry about the next couple of slides for now, that the autonomic nervous system, when we get to the autonomic nervous system, and we will that it has the superior control over your blood pressure, and we will learn that later on, so we don't have to sweat it now. But we will understand that the medulla has the medulla of the brainstem, medulla oblongata, has the cardiovascular control system. The hypothalamus also regulates the blood flow, and we will also understand later on that there are hormonal influence, either coming from the suprarenal gland, and that will be the adrenaline and noradrenaline, or it's coming from the hypothalamus, and that will be the vasopressin, or the angiotensin 2, which is a product of angiotensin 1. And we will learn when we get to the kidneys the importance of angiotensin 1, angiotensin 2, and the renin system. We will learn all about that. But just enough for now to understand that the arterioles have both intrinsic regulation, extrinsic regulation. Extrinsic regulation, either sympathetic innervation. There is no parasympathetic innervation for the blood vessels, for the arterioles. There is none, except in the genitals, in the penis and the clitoris. Now, in addition to that, we have hormones. Once they get into the blood, they're hormones. So we have adrenaline, noradrenaline, they're coming from the suprarenal gland, and then we have vasopressin, which is antidiuretic hormone, and we will have angiotensin 2. Okay, and we will talk about these two mainly when we get to the kidney system, and you will be able to appreciate it better. Okay, that's a summary slide that I skipped. So we passed from the arterioles, and because of this high resistance we have in the arterioles, then the pressure downstream from the arterioles will be very affected. So it will be drawn to minimum at this point. And why? Because the capillaries really have very thin wall, and if the pressure is high there, they will rupture. So you don't want the pressure to be too high. You want the flow to slow down there, although you're distributing everywhere, so collectively it's not really slowing down, but in each individual capillary it is slowing down. Why is it slowing down? Because you want exchange of gas. If the flow is so rapid inside each individual capillary, you don't have time to exchange carbon dioxide and oxygen and metabolites and nutrition. So everything is really designed here for a purpose, to maintain the homeostasis. So let's go back to the capillaries. It's very thin-walled. Why is it thin-walled? Because to allow the exchange, to allow the diffusion, to allow for things to go in and out, the metabolites, the metabolic wastes, all that, it needs to go in and out from the capillaries. So it has to be thin. The pressure inside is not much. You don't want the pressure to be much, otherwise they will rupture. And to counter that, the diameter is very small, so what do? You increase the number of the capillaries so much, so the resistance will not be huge, because now you have increased the number. You remember our very early example we had in video 1, where I told you you can drink from one very thin straw, or you can choose to have 100 of thin straws and drink through them. So that's what happens here. We have hundreds, thousands, millions of capillaries, and that will allow the blood to continue to flow through, but collectively at the same level. Okay, so again, it's a perfect place for exchange. We're maximizing the surface. We don't have much of a surface really. It's just one single, we don't have much of a wall, one single layer of endothelium, and even that layer has gaps, pores in between them, and those pores will allow things small enough. It has to be small enough so all the minerals, glucose, water, small amino acids, all of these things will go very freely through this. Anything that's fatty acid, everything that's lipophilic, however, fatty acids, cholesterol, lipophilic hormones, oxygen, carbon dioxide, all of these things would rather go through the wall of the endothelium, and they will go by diffusion from one compartment, which is the blood, into the extracellular space, which is outside those capillaries. So let's talk a little bit about the types of exchanges. One of them is diffusion, and we learned that in biology. You go from the area of high concentration into the area of low concentration. If the inside of the capillaries has more glucose, then the glucose will go out, and if the inside of the capillaries have more oxygen, then the oxygen will go to the extracellular space. If the opposite is true, or the interstitial space, if the opposite, like carbon dioxide, if carbon dioxide is higher in the interstitial space, then carbon dioxide will flow back to the capillaries, and therefore the capillaries will pick up the waste metabolites on their way back. Okay? The bulk flow, that is really a lot of other things. It doesn't pass through the diffusion thing, but it has more mechanisms contributing to it. Amounts, but it's not as big of amounts as the diffusion. It's lesser of amounts, but they will go in bulks. The water, and but without proteins, among other things, that will go outside the cells and from outside the arteries through these pores, not diffusing through, but big amounts that will pour through. It's not the main path for exchange between the blood and the interstitial space. The main exchange is the diffusion. However, we can play with the bulk flow by many factors. By, for example, increasing the pressure inside the capillary. If you increase the pressure in the capillary, you will increase what we call the hydrostatic pressure, and therefore there is more of what we call the bulk flow, and it can increase so much that the pores are widening away from each other, and therefore you will start leaking some proteins or even blood vessels, but not blood cells at that point, and we will see that later on. But however, we have the diffusion and we have the bulk flow. If we are to describe the capillaries, as I told you earlier, it's narrow, and they have very small gaps in between the junction of the cells, and those gaps, we call them pores, will allow the exchange. It will permit the passage of water-soluble substance and the lipid-soluble substance. As I told you earlier, it will go through the endothelial cells, dissolving in the in the lipid bilayer, and it will go to the other side, to the interstitial space. Now, the size of the pores, as we will learn when we get to the kidney and so on, will vary. Also, the intestine has much bigger pores. They will vary from one organ to organ, and that will allow the diffusion. If we look here, this is a nice picture for how the capillaries look like. And you see how thin they are. Here's the blood. Here are the blood cells. It's almost as big as wide as the diameter of one red blood cell, and that will allow maximum interaction between the red blood cells and the extracellular space, so they can the substances like oxygen can easily diffuse from the red blood cells into the surrounding environment, and therefore nourishing your tissues. Okay, so under resting conditions, the capillaries are not open, and you will say to yourself, wait a second, the capillaries are not supposed to have muscles, so what opens them, what controls them? Well, we have two mechanisms. The endothelium can sense the need for, again, with the active metabolites that are produced, and therefore it can play with the size of the pores. Those pores are not static, they are kinetic. You can increase the size of the pores, therefore you have more bulk transfer, or you can reduce them. So this is one way to play with it. The other way, the flow through the capillaries is controlled by valves, and those valves are at the end of the meta-arteriole, at the end of the arterioles, or what we call meta-arterioles. Those sphincters, it's almost like a shut-off valve. If I would close them, then the blood is not going to go, and you will see that in the next picture. The blood is not going to go to these capillaries. So if I think this is the arteriole here, and this is a meta-arteriole, it's not a capillary yet, but you will see here that it is surrounded by smooth muscle fiber. If I don't want the blood to go this way, then I'm going to shut down the meta-arteriole. But again, if you have a metabolic demand for increasing the blood flow, like low oxygen, high carbon dioxide, then I'm going to relax this smooth muscle fiber, also these guys, which are pre-capillary sphincters, and therefore I am increasing the blood flow. See how it goes? All right. So what I want you to remember here, please, is that the capillaries are not just static when it comes to their flow capacity or to even the pore size. They change the pore size based on the metabolic demand. They also can be manipulated by several sphincters, which are valves, shut-off valves, that are located either at the meta-arteriole or right before the capillaries begin. Okay? So, and as I told you earlier, there is bulk transfer, and this bulk transfer will be subjected to forces. There are forces that are trying to hold that thing inside, and that will be the plasma proteins. The plasma proteins has osmotic pressure, and we call that the colloidal pressure. And in addition, we have other forces that are trying to kick it out, kick the water and the solute inside here out, like the hydrostatic pressure, the physical pressure inside here that tries to kick it out. The same thing on the outside. We have power that's trying to drag the water into that direction by osmosis. If that power increases so much, then more liquid is gonna flow through these pores. if the osmotic pressure here is not much, then you are accumulating the water inside the artery. So there are forces that determine to which direction is the fluid staying. Here is an example of how the molecules move. So for oxygen, carbon dioxide, fatty acids, everything that's lipophilic will indeed go through, anything that's lipid soluble will go through the cell membranes of the endothelium. Anything that's water soluble but small enough, and it will go through these pores. Anything that's big enough, then it will go the ones that needs to be exchanged, like hormones or whatever, they will go by vesicles, like secretory vesicles. Now, like I said earlier, you can increase the bulk transfer by increasing the pressure inside, or by manipulating the osmotic pressure, whether outside or inside. If you reduce the osmotic pressure inside, which is the function of the plasma proteins mainly, then of course you are not able to hold on to the water, and the water will start seeping outside because the power of the plasma proteins to hold on to it will be lacking, and therefore you have generalized edema. You have swelling everywhere. And I told you in the class how people with severe malnutrition can get into that kwashiorkor, where they have swelling of their belly because of the accumulation of liquid there, ascites we call that. Also, people with kidney failure, when they start losing proteins, valuable proteins from the blood into the urine, then the colloidal pressure here you have is significantly reduced, and therefore the water is going to start escaping out, causing generalized edema as well. So oxygen, carbon dioxide, glucose, all of that will go by diffusion from the area of high concentration to the area of low concentration, as we discussed. Okay, so what happens to all these things that are leaving the capillaries? Well, they're supposed to be picked back by the capillaries, theoretically. But that doesn't happen in a perfect world. It will happen, but it doesn't happen. So we need another drainage system to clean the remaining, especially the big things that died, bacteria that came, some cells are breaking apart and releasing a lot of things, proteins that are made in the tissue and needs now to be cleaned up, something. How do we clean up that? We will start using the lymphatic system. Lymphatic system is another network. In addition to the blood vessels, has lots of vessels. It will start as initial thin lymphatic blood vessels, and they will go first into a cleaning station, which we call the lymph nodes, where we have, as we will study later on when we get to the immunology, blood cells, white blood cells, waiting for action and waiting to destroy the invaders, bacteria or anything that came in, and they're waiting there for their antigens. And then when it passes through that, it will go to major lymphatic blood vessels, to the thoracic duct, and then it will go into the major venous circulation. So we don't have to worry much about the initial lymphatics, and all what we need to understand now is that they are the drainage, and because they are the drainage system, you need to have a bigger pore than the one you had in the capillary. Remember, you had in the capillary tiny pore that doesn't allow big things, but now you have bacteria and you have proteins, so you have to have what we call overlapping edges. It has endothelium, but as you will see, the endothelium is not completely shut. It allows for bigger things to get inside the lymphatic circulation, as you will see in a short bit. We don't have to worry about the lymph nodes for now, because that's something related to the immune system. But we need to understand that the lymphatic circulation has lots of function. In addition to drainage, its immune system playing a really crucial role in maintaining the extracellular fluid, the balance of the extracellular fluid. It also carries heavy things, proteins. It carries even the fat that you are absorbing from your intestine, the chyle. It will go through the lymphatics because it's too big for the blood vessels to handle, so it will rather go through the lymphatics, as we will see when we get into the digestive system physiology. So as I told you earlier, the blood vessels of the tiny vessels of the lymphatic blood vessels, they have overlapping edges of the endothelium. You see this, and that will really allow things to slide in through. It's not like pores. It will push one edge down and then it will slide in. And that's of course one reason why when we have infection like sinusitis or something, a big pimple in the face, and you will start to see lymph nodes being large because the bacteria and whatever is there, it will start to go into the lymph nodes and causing inflammation there, or at least the as we will learn later on, the white blood cells will start to proliferate, and when they proliferate, then you start to feel the nodules in these lymph nodes. Nevertheless, once again, the idea here of having the lymph node, the lymph vessels, at least to us, is the fact that you have in the arteriolar side, it will end with the capillaries. From the capillaries, things are leaking out. That is supposed to be picked up by the capillaries on the venous side, but that doesn't perfectly happen. So in addition to that, you will have the sewer system here, which will be your lymphatic circulation. Okay, and from the lymphatic circulation, you will go to the lymph nodes, and from the lymph nodes, through series of valves, you will end up into the venous circulation. Okay, now the functions of the lymphatic system, as I described earlier: the return of the excess filtered fluid, defense, we will learn that a lot when we get into the immune system, transport of absorbed fat, and the return of filtered protein. Why is that? Because the proteins can't go back to the capillaries. Now we need to understand that if you would to increase the hydrostatic pressure significantly, lots of things will start leaking. And we see that with congestive heart failure, for example, when the pressure inside the veins is high enough, and it will cause retrograde pressure on your capillaries, and therefore the capillaries will start leaking fluid, and therefore you see edema mounting in the feet, for example, of people with congestive heart failure. Now, it can happen also because of a disease in the lymphatic system. If you block the lymphatic system, for example, a person who had a surgery, breast surgery, and we removed the lymph nodes because that is something we do, especially if it's a large enough tumor, then the lymph nodes are supposed to drain the lymphatics from the skin. So you will see for a while that the skin of that person is thick and edematous. Why is that? Well, because you removed the lymphatic system away from the drainage area, and therefore you have accumulation of fluid in the skin. And the same thing, by the way, happens if a person has massive invasion of the lymphatics in cancer, and you will see the surrounding area of the skin will start to be more edematous, and in the breast sometimes we refer to it as pédorrhage, and especially when it's associated with pulling of the fibrous tissue. But we don't have to remember that for now. Anyways, back to the lymphatic system. We can disrupt the lymphatic system, and I gave you an example of surgical removal, for example, of the lymph nodes, and that will disrupt the lymphatic system until the body figures out other mechanisms. And the other thing is that we have another like parasite worm that is transferred by mosquitoes, and it would live in, it would come to the skin and become really big worm, and will live, it prefers to live in the lymphatics, in the big lymphatics, and really big worm. And when it clogs the lymphatic system, then the lymph is not draining anymore, and therefore will lead to accumulation of the fluids in the skin, as we will, and in the tissues, as we will see an example of a patient who has elephantiasis, where the lymph is accumulating, so the interstitial tissue is really full and full of water and other things. We will see how that affects. Okay, so that tells us to talk a little bit about edema, and that's essentially swelling of a tissue. You have more water in the tissue than it should be, so you have more of the extracellular fluid than it should be. And the reason for it, it can vary. Either you block the lymphatic or you increase the venous pressure. And remember, when you increase the venous pressure, that will allow retrograde pressure to build up in the capillaries. Therefore, the hydrostatic pressure inside the capillaries will be high, and therefore more leaking will be happening through the capillary pores. And when it leaks, then you have more edema, right, in the skin and in the tissues. You can increase the permeability, and we're going to learn about that when we get into the inflammation as part of the immune system. When you increase the permeability, then there is more leaking, of course. So, and as I told you earlier, if you lose the power to hold on the water, and you lose what we call the colloidal pressure, then the water will go out. All of these reasons can lead into what we call edema. Here is a case of a person with what we call elephantiasis, and you have that in your book, where the lymph circulation is blocked by this worm, and that will lead to very severe edema, and it's not even pitting at that moment because you can't even get it out, and that's again because of this horrible parasite. Okay, so we learned so far about the arterioles in this video, about the capillaries and the capillary circulation, and we got also into the lymphatic circulation briefly. So now we will talk about the veins. That's the last station. We started with arteries, went to arterioles, capillaries, and now we are getting into the veins. Venules, nothing much happened there, so let's get into the veins straight. So the veins, these will be the return of the blood, the venous return of the blood, the passage to return the blood back into the heart to be oxygenated in the lungs, as we know, right? The venules will merge to make larger veins, and those veins have fairly large radius. And because they have fairly large radius and not much musculature around them, they retain a lot of fluid, not fluid, but a lot of blood, and that's why we call them the reservoir or the capacitance. They can hold the capacity of the blood can be stored in them. That's a nice place to store them when you don't store the blood when you don't need it for now. Okay. So, but imagine you were in an accident and you lost, God forbid, and you lost a lot of blood in that accident. So what happens here is that we go to the reserve. Where is the reserve? The veins. And as you will see in the next couple of slides, most of the blood you have in your system is actually in the veins. And the veins are surrounded by musculature, although not as strong as the one we saw in the arterioles, but they have musculature, smooth muscle fibers. And when you constrict that, you reduce the diameter, and therefore you're not doing anything with the resistance here, but you're playing with what we call a very important word here, and I want you to remember this: venous return. You can increase the venous return. Therefore, you're employing more blood into being oxygenated instead of just letting it sit there for longer time inside the veins. So this is a very important thing the veins are playing to us, is to regulate the venous return. How do they do that? Because the veins are the place where most of the blood is held. Therefore, it's your reservoir to tap into if you need more blood. Get it? So, how do we enhance the venous return? Well, pressure from the cardiac contraction, that can enhance the venous return. And you can enhance it by sympathetic innervation, and that will cause vasoconstriction. Like we learned before, sympathetic innervation to the veins will stimulate the smooth muscle fibers. Smooth muscle fibers will contract, and therefore you have increased tone, and therefore you have more blood flowing back. Skeletal muscle activity, we will learn about the skeletal muscles being peripheral heart, and as you will see in the next couple of slides, when they pump, they squeeze the blood back, and that's a very important mechanism because the capillary pressure is very little. And remember, you need to imagine you're standing, and we're going to see some picture of that. You're standing and all the blood now is in your feet, and you want to pump it back into your heart. I mean, the capillary pressure is not that much to pump it back. It doesn't have the capacity to do that, but it will be aided by the muscles. How the muscles alternate the contraction, and they will start squeezing the blood back, as you will see in the picture, into your heart. And to ensure that the valves, the veins will have valves in them, to make sure that the the blood is only going towards the heart and not away from the heart. And that's a very, very, very unique thing. The only vessels, blood vessels, that have valves are the veins, but also, of course, if we talk about all the vessels, the lymphatic vessels have valves as well. But the veins here, when we refer to the blood vessels, the only one that has valves would be your veins. Okay, and we'll see that. Respiratory activity, every time you inspire and expire, you are causing squeezing of the blood vessels that you have in your lungs, and that in itself also will help as a peripheral heart, squeezing the blood into the heart and sucking the blood from the pulmonary artery into your lungs. And we will learn that more about when we get into the respiratory physiology. As I told you at the lecture, when you empty the atria to the right atrium to the right ventricle, that will create a vacuum, right? Because the fluid just dropped, and that itself will suck the blood from the superior and the inferior vena cava. So all of these factors can indeed play a role in enhancing the venous return. If I hold a comparison between the different types as we talked earlier, here is the artery, and the artery has the endothelium, the elastin fibers, and then smooth muscles, lots of smooth muscles, and then other elastin fibers, and then very dense connective tissue here with mostly collagen fibers. Now, if we go to the arterioles, we lose most of the connective tissue. We don't have the elastin fibers, but we have some musculature, and we have still the endothelial. We go into the capillaries, we only have the endothelium, and when we go to the veins, we don't have the elastin, but we have some connective tissue, some collagen fibers, we have smooth muscle fibers, and we have the endothelial cells, and inside the endothelial cells can form themselves to make valves, and therefore ensuring the blood to go on only in one direction. As I told you, the veins, which is this area here in this pie chart, is the one that's holding most of your blood. So it really makes sense when you want to tap into the reservoir, you tap into your veins and cause vasoconstriction, venoconstriction, we call it venoconstriction, into your veins, because you can use this blood to nourish some more important regions instead of just letting it sit there in the veins. Okay, so as I told you earlier, that the venous return to the heart is really aided by the muscle contraction, and that's a very important thing, because as I told you, there is nothing pumping the blood back. I mean, the capillaries have such a weak pressure, so it's really the pressure from the muscles and the contraction from the muscles is aiding the return of the blood back. And when this, of course, fails to happen, here is an example how the muscles are squeezing the blood into the veins, and how because of these valves, then the blood is never going to return back to the original, and then the original site, and therefore it will just continue to go into one direction and one direction only. When that fails, then we have a situation which we call varicose veins, in which those valves are destroyed, which are linking the superficial veins to the deep veins, and then you start to have the veins showing up under the skin, very, very visible, and sometimes they get coagulation and clotting and infection even sometimes, and it becomes very painful. So in many cases we do surgical removal for these varicose veins. Okay. Sometimes the veins will allow too much blood to be staying in, especially if you're not that physically active, and we notice that, we call that postural hypotension, where you stand up suddenly and then all of the blood stays in your veins because your muscles are not really supporting the veins well, and therefore you lose, you feel dizzy and you feel blackout, and then you may want to sit a little bit before you try again till your muscles gain their tone back and push back on the vasculature, or at least till your veins constrict and therefore push the blood back. So that happens, and we call that postural hypotension. Postural hypotension. Okay, so the last thing here to talk about is the mean arterial pressure. The mean arterial pressure, what determines it, how strong the heart is pumping, the cardiac output, and the total peripheral resistance. So if I increase either of this, it will increase the mean arterial pressure, When that increases significantly, then of course I will end up with a situation like hypertension, and we learned about the hypertension at the lecture, but we will talk about it today briefly. This is not an internal medicine lecture, this is a physiology lecture, so we will only refer to it slightly. The blood pressure has to be constantly regulated, and we have receptors for that. Receptors in the hypothalamus, that's in the brain, and receptors sitting around in major arteries, like in the aorta. We call them baroreceptors. In the carotid sinus, we'll learn about the carotid sinus later on. All of these guys are trying to make sure that your blood pressure doesn't fluctuate, because that can lead to serious problems, as we will learn later on. Either you will feel dizzy and you will fall if your blood pressure is too low, or it will be too high that will start causing disease for you. So you want to regulate that pressure, and we have short-term adjustment that will occur within seconds, right? Immediate. And the adjustment will be alteration of the cardiac output, the total peripheral resistance, all of these things will happen immediately. Now the long-term effect, and it will take the blood volume. You will start to regulate your blood volume. You will secrete some hormones like vasopressin or angiotensin. How the angiotensin comes, we'll talk about that when we get to the fluid control, and that's part of the kidney, or after the kidney, after we learn about the kidney physiology. And all of that will be aimed into reducing the total volume. So you can reduce the blood pressure or increase the blood pressure by manipulating either the vessels or the cardiac output, and that happens immediately, or something that takes more time, playing with the water balance, playing with the urine output in an effort to control the total blood volume, and therefore you are regulating your blood pressure, but that will take longer time, of course. As I told you earlier, we have something here called the carotid sinus, and as I said, it's at the bifurcation of both the deep carotid artery and the superficial carotid artery. And if you apply pressure to it, as I told you, which is not recommended, it will actually reduce your blood pressure, because you will be telling this sinus here that you have too high of a blood pressure, and the immediate reflex that will go to the hypothalamus, and therefore it will fire back as parasympathetic, with the parasympathetic innervation here from the medulla, not the hypothalamus, sorry. It will start firing parasympathetic stimulation that slows down the heart rate, causing vasodilation in an effort to reduce your blood pressure, because now the baroreceptors here in your carotid sinus told you as a medulla oblongata that your blood pressure is high, right? And the same thing, we have here other receptors in the arch of the aorta, and we'll learn about that again when we get to the autonomic nervous system, that indeed they will sense changes in the pressure, and therefore they can communicate with the medulla oblongata. Is the only thing that regulates the blood pressure just the pressure? No. More things. Osmotic pressure will also regulate it. So we have sensors to measure the osmotic pressure for you. We have sensors to measure how much carbon dioxide you have, how much oxygen, not oxygen, but carbon dioxide, what's your acidity in your blood. And all of that, of course, will influence your blood pressure one way or the other. Okay, so here are the additional mechanisms. We have chemoreceptors, and we'll learn about the chemoreceptors later on, and they will sense low oxygen, high acid levels, high carbon dioxide modes. You're afraid, or you watched something that is sort of scary, your blood pressure will go up. Vasoactive substances from the endothelial cells, they play a role. Many other smaller things that also contribute to the regulation of the blood pressure. Couple of words here about the abnormalities of the blood pressure before we conclude this chapter. Hypertension is a blood pressure that's above 140 by 90 millimeter mercury. Now, of course, they are revising that, so I think the latest is 135, and even now they're saying if your blood pressure is between 125 and 135, we will call that pre-hypertension. So they keep changing that. The hypotension is if your blood pressure falls below 100/60. Okay. Many reasons for hypertension, and we will learn more about it when we get into the regulation of the fluid intake, because that will be really related to the kidney. So I'm not going to spend too much time on the reasons. We have, of course, genetic reasons, but excessive salt intake, defecting in management by the kidney, you have a problem in the kidney in excreting the water. Many problems can lead to that, and they're all theories, and we don't necessarily know what's happening. Or increased sympathetic, consistent increase in the sympathetic innervation. That can also, that's why we think stress can be a risk factor for hypertension, because you're all the time activating the sympathetic innervation, and therefore you're elevating your blood pressure. So stress can indeed cause, by the way, stress can also release more cortisol, and cortisol in itself, as we will learn later, can retain sodium, and when you retain sodium in the kidney, then you have more blood volume. We will learn that in the kidney. You don't have to worry about these details now, but there are many factors that are attributing the stress to the elevated blood pressure. Okay, so hypotension. No, we're still at the hypertension. Secondary hypertension, all of these were primary hypertension, when the reason we don't really know. But if we know the reason, like the kidney is failing, endocrine problem, like you have a tumor in the suprarenal gland and that gives you too much aldosterone, for example, or you have a problem, neurogenic problem, you have like pheochromocytoma, which is a tumor of the adrenal medulla, and therefore you have too much adrenaline and noradrenaline. All of that can lead to hypertension. You don't have to worry about the pathological situation in this chapter, because again, I want you to understand the physiology, the basics of the physiology, not necessarily the clinical aspect of it. Okay, complication, we know that hypertension is a big problem. It can cause heart failure, congestive heart failure, it can cause stroke, heart attacks, spontaneous hemorrhage, renal failure, retinal damage, all of the above. So hypertension is a serious problem. Hypotension is when the pressure is low. There is a common type that almost all of us have experienced, which is the orthostatic or the postural hypertension, when you stand up and the blood goes to the veins, and in the lack of tone, a good tone to support these veins, like when you are tired and so on, or your muscles are not supporting them well, then the blood is rushing there, and all of a sudden you will experience a transient lack of blood flowing to your brain, and that's when you black out or you feel dizzy and you want to sit or grab into something. Okay. If it lasts too long, that you have a hypotension and sudden hypotension, you can get into circulatory shock. We don't have to discuss it too much. Again, this is not an emergency medicine lecture, but you don't have to remember the following words, but we have 4 types of circulatory shocks. Either you lost too much volume, as in hemorrhage, or as in burns, and or dehydrated. You are dehydrated. All of that will lead to hypovolemia, or the heart is not pumping, and that will cause also hypotension. If the blood vessels give up, all of a sudden all your blood vessels are dilated, and that can happen, by the way. And we'll learn about that in the immunology. And so all of a sudden everything is dilated. Or neurogenic, your sympathetic system gives up, and all of that will result into circulatory.